And I'll turn out my video off. Focus on.
So do you have the slides?
Yes, I can see your slides. Good.
Okay.
Okay, so we've got Maria, Lane, Hassan, Felice is here, Richard, Suma, hi Suma, and then we'll see if more come.
Okay.
So I lost your slides now.
So you have the slides. Should I start?
You turn off your video.
Oh, I should turn on the video.
Sorry. Yeah. So now we had your slides before, and now they're gone.
Okay. Let me see. Stop sharing. Share screen.
He wanted to join. Okay, now it's on. The slides are on. I'm going to mute myself now. It's all set, Nader.
Okay. So good evening, everybody. Since last year, one of our colleagues in Japan started working on the issue of neuroethics of AI. And the reason was that in Japan, it appeared to be serious issues regarding regulation of this new technology. And I became a member of his team, and we started doing a little bit investigation about the potential problems of using neurotechnology along with AI, and how serious ethical issues may happen, especially regarding the commercial use of this technology. So that is the main point of this presentation, but I have some slides which explain a little bit about the basics of neuroethics. I will pass through them fast. This slide explains that neuroethics is basically something that started, the term started in 1973. But the field became important in early 2000s. It studies ethical, legal, and social implications of neuroscience and neurotechnology. There is a little bit of philosophy in it, a little bit of ethics in it, and a little bit of science, neuroscience in it. What are the important areas of neuroethics? We have clinical neuroethics, for example, psychiatric treatments, end-of-life decisions when people have brain injuries, things that have been common topics in ethics. We also have research neuroethics, for example, doing brain research using animal models in neuroscience. The interesting thing starts with some technologies that now claim they can enhance cognitive abilities of people. So we have now the concept of cognitive enhancers. Some products are already on sale for that. You can buy them. They are commercial. They're not regulated. The claims they make sometimes are very big, but these claims have not been studied independently and have not been, approved or verified. However, they're being sold. They do a lot of things, improve your memory. If you have an anxiety, you can treat it. If you have depression, they make a lot of different claims regarding that. The next area, which was the focus of our research, was the issue of brain privacy. So a lot of these machines, these commercial products, they try to record brain waves or do something similar to that, gain some data from people using these products. And usually the data gets uploaded into the servers of these companies. And after the person even stops using, still the data could be with the companies for nobody knows for how long. So the issue of recording these and how this information can even in the future be used to gain some more knowledge of these people is one specific issue in brain privacy. Other than brain waves, there is the issue of neuroimaging, trying to read the mind of people, even trying to understand whether a person, for example, is telling a lie or is being truthful, or our memories are true or not. The other thing is the addition of AI technology, so that these machines can actually, using AI, train their systems to gain a better understanding of, for example, these brain waves in this person. They mean he's thinking or remembering something. What is he remembering? Trying to make sense of it. And the AI is playing a big role in decoding the information collected from people. So the issue of neuro privacy is one of the fundamental issues of the current discussion. So it talks about the right of people to keep their own neural information private for themselves. And there are a lot of information that can be classified as such. Brain activity patterns, like from EEG, functional MRI, the emotional states of people when they are being recorded, memories, thoughts, health information related to their neurological system, and behavioral patterns. So there is a wide scope of neuroprivacy, and it's not limited to medical settings. Now, with these products that are being commercialized, consumers are prone to, losing their privacy when they're, accessing the systems of companies that have sold them these products. Uh, so there's a lot of discussion about that. The precision of neuroimaging techniques is improving. There's a better understanding of what these brain waves hold, and some claims are there that they are not really much verified, but you might have seen that, for example, they say they produced a picture from what a person was trying to think about. There are such claims. They have been widely distributed on the internet. Um, we were not able to verify it for ourselves, and some of them seem too exaggerated. But in the future, that may be the case, meaning that they can record your brain waves, and whatever you are thinking of, the AI produces an image of it based on the data it has received, and based on the training it has gone through. For example, you thought about something and you trained the computer, the AI system, what you were thinking of, and gradually it learns. There are certain challenges in neuroprivacy, like all this information comes in one big package, and you don't know how you will be able to separate certain information from others, like emotional information from memory or what. And this data can later be examined, and there's a lot of complexity in it. The important issue, of course, is whether we have benefits from using this. And a lot of people, especially in Japan, are very optimistic that these technologies will be helpful, especially we have an aging society. They think that AI in the future will help them, for example, if their body cannot move, to move them around, and mobility and connection and communication. A lot of things might be helped using this. So they're focused on the benefits, but they are a little bit insensitive to the possible misuse. and the other ethical concerns of this. Who are the stakeholders, like researchers, clinicians who are thinking of the possible benefits, companies who are investing in neurotechnology products, policymakers, regulators, ethics committees also. And we are hoping in the future we can educate people more about their rights regarding their neural data. One issue is the importance of getting informed consent from participants. Very often there is no such thing, and people simply go through, the information as a consent, form, and just accept it without understanding the complexity of data they are sharing. So data security and protection, long-term storage of this data, who owns this data, and can these data be anonymized? Really? Probably not. And as I said, there's a band of all data, and separating it so far doesn't mean anything. So mental privacy is a big issue. Will companies have access to our thoughts, to our emotions? Will these data be useful, for example, for advertising, or for spreading misinformation, or for reading the mind of people, learning how they can be manipulated, or in the case of government, to be nudged into doing certain things? There are some other ethical issues also possible. Discrimination based on, the neural data that is being read, for example, in the case of employment. Uh, you know, uh, I will tell you about some cases that are already happening, and at the workplaces. Stigmatization based on differences in neurological data. Uh, we talked about enhancement, so let me pass through this. So is it possible that companies can manipulate people and coerce them into certain behaviors? Uh, will it be used by, for example, even the military, or certain governments, to try to coerce people into certain behaviors? Is it possible that neural data will be commercialized? You see, for example, this project of neural link by Elon Musk, who again, he claims it is going to help people who are paralyzed to be able to use this chip that is planted, under the skin to control some activities. But is it going to also be used for other, form of, commercial use for companies? What is the perception of the public? There's a very low level of awareness, and especially in the case of Japan. I've heard in Europe, people are more pessimistic, but in some other places in Asia, that kind of optimism exists. There are some common concerns. A lot of it is based on, for example, what people have seen in the movies, in media, pop culture, the fear of intrusion into their thoughts or reading their minds, and an anxiety over misuse of neural data. How it is portrayed in media, science fiction, how the news of neurotechnology advancement is being covered, how social media portray this, and how discussions lead to people's perception of neuroscience and its ethics. The personal experience is quite limited, but in medical settings, for example, if people want to, for example, with paralysis, if people with paralysis want to use AI and these systems to move certain things, or communicate using their computer screen. They may have used some of these devices. Some of them are even being used by researchers. Some companies actually manufacture products that are being directly like advertised to research institutions, and still they're collecting data, so the researcher is supposed to use it for the patients, but the company also gets a share of the data. Some cultural and religious beliefs that also have an impact on how people perceive these technologies. The level of education, scientific literacy. Uh, of course, we don't have that much of neuroscience education for most people, unless they're in medical, they have a medical background. So it is important to include these talks because these technologies are advancing very fast. There are a lot of regulatory challenges. The only countries that are trying to catch up with the advancement of technology are in Europe. The US and Japan are actually leaving most of the work to the companies themselves and to the businesses. There are some concerns about the dual use, both having benefits and also benefits for the user, but also some potentially harmful use by the companies or governments who have access to the data, and how these regulations can be enforced. Is it possible? Commercial use of these products is, very often based on a consent form that is just being ticked by the user, and very often they are not being controlled, monitored by outside, companies. There are some famous case studies of it, like Facebook, which is now called Meta, started a project that would help people to do to typing on their keyboard, but they stopped this project. The project was discontinued. A lot of issues regarding transparency became controversial. Elon Musk's Neuralink is quite now, popular. People talk about it a lot. Uh, the use of EEG for detecting truthfulness or lie detection, even in courts. There have been a few cases in the US. There are a lot of products. I have a file that it is done by researchers who looked at the commercial products using EEG headsets, and there are more than 50 companies which are now selling them. Some of these headsets are used for research, some of them are used for gaming, some of them are used for claims that are unfounded. Uh, all the issues of privacy and other concerns, data breaches are there, but there is no control over them. There was this brainwave surveillance in Chinese factories. So some workers were told to wear EEG sensors to monitor their fatigue and also their emotions while they were working. So the ethical issue of employee privacy, consent, and the potential for coercion was there. Neuroimaging, use of functional MRI for consumer behavior studies, like finding a buy button in the brain so that companies can coerce people to go shopping for certain products. And they're actually making a very good progress in that area. So brain data are also collected in clinical trials. There are some military applications. There is this U.S. Research Institute with, military research, DARPA. So they're working on brain-computer interface, dual-use technology. So the issue is whether we have this technology for national security or we are stepping on individual rights regarding what is happening inside their brains. And as I told you, some of these companies claim they can treat depression by these neural implants. It has not been verified and approved, but it's already being on sale. There are many challenges for the future. Technology is advancing very fast, and how can we implement privacy by designing the way that the neural technology is doing its job? Is it possible to do that? Is it possible to have transparent AI systems for processing neural data? There should be a lot of work on that. Some other emerging ethical dilemmas, like the issue of cognitive liberty, cognitive enhancement, neural rights, uh, the issue of whether AI will become integrated with human cognition. We will have like a symbiosis of human AI at the level of directly at the level of brain, where, for example, like something like a cyborg or something. There are some even philosophical considerations, whether there will be free will or there will be a lot of manipulation, coercion, and how we can redefine consciousness when machines are having such a big impact on how we are even thinking, and what would happen to human identity. So this is close to the end of my presentation. The key takeaways: rapid advancements of neurotechnology requires a lot of ethical consideration. Neuroprivacy is a very complex issue. It includes legal, ethical, and social dimensions. The public perception needs to be improved, and we need to provide much more information to the public. The current regulatory frameworks are insufficient. They have to be, improved, and they have to be dynamic, and they have to go hand in hand with the advancement of technology. So how can we ensure that there will be equity in access to the benefits of these nanotechnology? At the same time, we can protect privacy. What would be the appropriate use of neural data in various contexts, whether it's medical, commercial, or legal, and how society should address the potential for cognitive enhancement, and what should be the role of government, industry, and academia, especially ethicists. And yeah, that was mainly it. And yeah, if you have any questions, I will be happy to answer some of your questions. I can share some of my, some of my other files also, and especially the file I told you about the commercial use of it. But if you have questions, I think I have used my 20 minutes. Thank you very much for listening.
Thank you very much, Nader. Sorry, I forgot. Yes. And I have a reflection. Uh, uh, Fresh. Uh, in Turkey,
Yes, yes.
there is an effective politician, and 2 months ago, he went into a cardiopulmonary surgery operation, and from at that time, nobody saw him, and often, I think I may almost every day he publish Twitter messages, and all of his followers know that the messages are the same, but nobody knows is he alive or not. And also one more thing, and last a few days, some people says we had got telephone with him, but many people think that it is impossible because he died. Yes, this is a very important issue, as you mentioned, neuroprivacy.
Mm.
And the AI is also make a cognitive a profile, and also it acts like the person himself.
Yeah.
And as you know, we have studied on an article, and also neuroprivacy is maybe the most important issue of AI and health ethics. Okay, thank you very much. And like all time, I learned too much from your speech.
Oh, thank you, thank you. No, I thank you very much for that example. Yes,
Nader.
As you mentioned, yeah, AI can now try to profile people, to imitate even their voice, and to try to copy some of their attitudes, behavior, the way they write, and this is actually how AI trains itself. And yeah, so very interesting case. Thank you. So back to you, Daryl. If there are no more questions, we can continue to the next presentation.
Does anybody else have any questions for Nader?
So thank you very much. I will be listening to the next presentation, and I'll be looking at you.
So I have a question though. So do you think an AI, at what level of intelligence does an AI deserve the same respect for privacy as you believe a human does? And think about also the application of Peter Singer's arguments that some humans are not as smart as some animals, and some humans are not as smart as some AI already. So in those cases where the AI is as smart as some human beings, does it deserve privacy?
My thinking is that AI is not intelligent. What it does is that it has access to a much larger amount of information, and it can process the information very fast. And how it behaves depends on how the algorithms by the designer instructed to behave. And there is also another level, deep learning, that sometimes even the designer is not sure what it does. So we have this issue of whether AI work can be explained, and they have realized that AI can, for example, act as a racist or do stigmatizing behavior. So we really don't know if AI can be smarter than humans, but it is a very powerful tool. And there's not one type of AI. As you see, for example, in China, they released this DeepSeek, and I know some people who have compared ChatGPT with DeepSeek, and they say DeepSeek in some areas has a much better ability to to find solutions and to give better answers. So there will be many different versions of AI coming out. Some of them are going to be much better, much more powerful, but again, it's not, I think, still we cannot say AI is an intelligent, uh, how to say, being there. Still, I would like to treat it as a very powerful tool, and depending on how humans want to use it, it can be beneficial or it can be manipulative, and it can be used for coercing and spreading disinformation. And in governments, they can use now AI for what they call nudging, to make people behave better in a democratic society, they say. So there's a lot of them, controversy around it. So yeah, your question is a very difficult one. What do you think yourself?
Okay, so I'm going to ask you an maybe even more difficult question. About 15 years ago, I remember, or 10 years ago, you may have been there, Professor Tsuyoshi Aiwaya, one of our dear friends from Japan, talked about sex robots.
Yeah, I know.
So let's now, and if you've seen the most recent robotic conferences with AI robots have been interviewed by the media in the last few weeks. So we create a sex robot who will only want to have sex on certain days and give consent. So can we have a rape of the sex robot who's not in the mood? What do you think?
Yeah, like in Japan, I read that there are like 2,000 people who are in a relationship with an AI character. No, I don't think currently these programs have rights similar to humans. Not now. The way they are designed and the way they respond, but I don't think any court would agree to treat them like a human and would give them, human rights. But it would be for example, disagreement regarding, the way a machine can be used. For example, if there is such an agreement in the beginning that there are rules how you should, especially if that character still is on the server of the company, not on the personal computer of, the person holding it. So I don't know, maybe in the future that will change, but I think so far there is still more like machines, not having human, rights. But maybe in the future, we will have humans who get an AI addition, and then we will have a cyborg, which is part machine, part human, and then we should think about human rights. Yes.
Okay, well, if maybe I'll send one of these dear friends to your office and knock on the door. Okay. Hassan,
And neither medicine is founded on compassion. Yeah.
Yes.
I'm not sure love or sex is about compassion, but not no. So it's in near future. I think it is not so easy to make any AI to have compassion in medicine, and so medicine is human to human activity. It's, I think, a bit is something that help the physicians, nurses, but it's not the main character or main player of the medicine. I think almost in near future. And and there's some feelings for humanity is very is essential, and I think I consider that the humanitarian perspective and attitudes will be more important in future. Almost the AI is with us, but it is not only the technical issue in medicine. I mean, yeah, it's a great discussion. Thank you very much.
Thank you.
I would say add to that, probably the useful model that we have already in professional practice is veterinarian medicine.
Yeah.
Because veterinarians are getting consent from many animals before they will, for example, take their temperature up their butt, or fix a broken arm or leg. And so we do have quite an established ethic of dealing with animals. And in your judgment, you believe that AI is maybe more similar to some of the animals that are treated than it is to human beings in general. Of course, we also have a model for the treatment of unconscious or incapacitated or humans without the capacity for giving consent. So we do have these models. I think these may be useful starting points. Anybody, by the way, who has recommendations for the statement of a conference, including Nader, please think about it and send via Skype.
Thank you very much. Thank you. Yeah. I will consider.
Yeah.
Thank you very much.
Thank you. So, believe it or not, Mina, even though you were down in the agenda, since Dr. Sheriff and Manyao have not connected yet, and we also have two Bangladesh doctors who said they wanted to present who couldn't come, and they haven't joined. Mina, would you be able to present now, please?
Yes, of course. That's fine.
Thank you.
Can you see me? Yeah, I can see myself now. Can people see me?
We can see you still. Yeah, you're back there.
So it's reset. Good. Thank you. Do you want me to share my screen, or I did send this PowerPoint slide to you?
Share your screen. I think it's good. Yeah, thank you.
Okay, so I'm going to put my headphone on so that you can hear me better.
The sound quality is perfect.
Okay, still, I'll just keep it handy just in case if I need. All right, so thank you very much. I'm going to share my screen then. Then we'll start. It's after many years that I'm joining, so I'm very thank you very much indeed. Let me open my PowerPoint where it's gone. Okay, it's opening. Okay, all right. Just share the slides. Where is the Skype gone? Oh, okay. Sorry. Share screen. Here. Start sharing. Could you let me know that you can see my slides? Hello? Can you see my slides, Darryl?
Yes, we can see it.
Perfect, thank you.
Okay, so I'm going to put it on big screen. I can't see you all now, but hopefully you can see me. So thank you very much indeed, and I'm quite conscious that it's quite late in Bangkok and probably that part of the world. So I will keep myself short. But yeah, thank you very much for giving me the spot to share some of my thoughts on a project that I did some time ago in India. This was so today what I'm going to talk to you about is exploring how community health workers in India face challenges in terms of delivering the healthcare to pregnant women in India, and I'm going to touch a little bit on the ethics side of it as well. So let's begin. Let's start with the history of why this project and what is the rationale for doing this project. So if you remember back in when Millennium Development Goals happened in early 2000s, one of the goals was to reduce the maternal mortality rates globally in most of the countries, and India is definitely which has a very big problem of maternal mortality rates being very, very high. So what the government of India did, they said, okay, in order to reduce the maternal mortality rates, which used to be actually our rate was about I think 395 to 400 per 100,000, which is very high. So this started this program called Janni Suraksha Yojana, which is a safe motherhood program back in 2005, with the focus on reducing financial barriers for women and also narrowing the disparities by targeting weaker states in India compared to the states that were a bit richer. So this program was started so that women deliver healthy babies in institutions, or there is an institutional delivery of babies, not at home, with the help of skilled birth attendants. Now this obviously has doubled since that program has started, but as you can see on the left, my left, you can see some of the big states in India, central part of India, you can still see maternal mortality rates being very, very high, up to 173, 167, or even 195 per 100,000 live births. And compared to even countries like Thailand, which have got, I think, 23 or 24 per 100,000, or China like 23, 29 per 100,000, around those range, less than 30. India is still struggling with high rates of maternal mortality, despite starting this program. But so this is more or less a conditional cash transfer program. So there are two aspects of this program. One is paying women, pregnant women, to go to hospitals to deliver babies, like a cash voucher, and also to the community health workers who facilitates this to take women to the hospitals. So she gets a voucher as well. So it is for beneficiaries are in a way both of them, and it has worked. As I say, our rates are down by 70%. It used to be 400, now it's only 99 to between 99 and 103, the average. Of course, some big states are there, as you can see on the picture. Still, rates in certain parts of India are pretty high. So based on that,
I lost your picture. I lost
sorry?
your screen. Did everybody? Can other people see? I can't see the screen. Could you try stopping and starting your screen sharing again?
Okay, I can. Okay.
Oh, it's come back. It's come back now.
It's come back.
Yeah.
Okay, so this is called GSY, or Janani Suraksha Yojana, which basically means Safe Motherhood Program. So the role of community health workers is quite prominent in this program. So I can't now. My screen seems to be frozen. I need to move this one. Somehow the screen is frozen now, Daryl. I can't move this. Oh yeah, it's coming back. Okay, next one. So these community health workers are called as ASHA, which is an acronym for Accredited Social Health Activist, or ASHA. ASHA means hope in Hindi, and they were enrolled under the National Rural Health Mission program in 2005, and their main job is to facilitate the institutional delivery and also other community level mobilization for other health and public health promotion or health promotion activities. The criteria is very simple. When these women are selected, they are selected by the local government officials, but the woman has to be the reproductive age, 25 to 45 years of age. They must be resident in the village where they are going to serve their own community. She should not be a single woman. She should be married, widowed, or separated. And her education level be from in grade 8 to grade 10. That is a minimum requirement. Of course, she can be more educated. The training is now about a month. I think the depth of the course is increased, and and also the content level is quite intense now. And till date, I think India has enrolled about 1 million Ashas have been enrolled. And a set of population is about 1,000 women to 1,500 women per village she is going to serve. So that's a target for every ASHA who is a community health worker in India does. And they belong to not only rural areas, but they also belong to urban areas in the country. So what are her specific roles? So her specific roles are quite. They provide very comprehensive care to women. They do community mobilization for institutional delivery, or they also raise awareness about maternal health, child care programs, family planning, water and sanitation, hygiene and sanitation, and also they do counseling about nutrition, breastfeeding, and they also facilitate when the delivery comes. They also facilitate the access to the hospital for women. So there's a very multifaceted, comprehensive community mobilization role to these women have, and they do get an honorarium. They are not a salaried person. They're volunteers, but they do get honorarium for every institutional delivery that they facilitate for women to be in the hospitals. And so some of the cash that these women go is in the next slide, as you can see. If the women belongs to low performing states, LPS actually stands for low performing states, and high performing states. If the woman is if an ASHA worker or a woman belongs to a low performing state, she gets about 1,400 rupees, which is a 14 pounds, let's say an average, about $17. And ASHA will get $7 to $8 per woman, not per. And also, if she is in urban area, she gets paid less. So this is kind of a package that is given as a conditional cash transfer to ASHA workers as well as mothers in low and high performing states. So this is kind of an average. So there's always a motivation for them to, how many women can you bring to the hospital? That sort of motivation and encouragement is there for women to get more and more money. So what we wanted to do was, this project was funded by a European Commission for 4 years. It was a big project, and our role was to do an impact evaluation of the 2 national level programs, which one was the GSY program, and another one is called CY, which is Chiranjeevi Yojana. So today what I'm going to do is I'm going to focus only on one state, which is in Madhya Pradesh. So we were funded for 2 states. I'm going to talk only about one state and one particular aspect of the massive project that we did. So they were designed, both the programs are designed, as you know, to reduce financial barriers and also improve access to maternal health services for women. So in the project that the arm of the project that I was particularly involved was to explore the role of community health workers, the ASHA workers, about their own understanding of facilitating institutional delivery and promoting maternal health in rural villages, and also to do a survey of quality of care in private clinics participating in the government-led financing schemes, both in Gujarat and in Madhya Pradesh. So I'm going to focus only on the role of the community health workers, that arm of the project today. If you got questions, I'm more than happy to expand on what we were doing. The project is called MATIN, Maternal Health in India. So let's start. So this is me, as you can see, myself in the picture with one of my colleagues from Sweden, and we are in a village. Actually, this is a hospital in Madhya Pradesh, in a village where deliveries are happening. And so We did not cover the entire state. We covered only 3 districts in each state. So in Madhya Pradesh, where this picture was taken, we were in a place called Shahdol, which is a district area of a big state. And there were other 2 states called Panna and Ujjain in Madhya Pradesh where we did. So we were collecting data not only in 3 districts, but also at 3 levels in 2 states. One was, so we were covering collecting data at state health departments, obstetric care facilities, and also talking to women who have recently delivered or new mothers. We used quantitative and qualitative methods both in our study design, but today I'm going to speak only about the qualitative aspect of it. So as you can see, this is Madhya Pradesh, where I was based conducting research, and we took 2 districts for qualitative study. One is Shahdol and one is Ujjain, and that's where we met all these ASHA workers and interviewed and considered and also did focus group studies about to understand their perceptions and interpretation of their own roles in a very complex public health system, and what challenges do they face in delivering maternal health programs, and what impact does it have in their own lives. And how, because they are a very small part of the big complex program, what do they expect to gain out of the program, and also their own future. So we conducted actually 23 interviews, 23 interviews in both the district, and 5 focus group studies in these 2 areas of the state. So then when started analyzing data, so I wanted to take a little bit of an ethics lens to it, and not all of the ethics, because there are a lot of health inequities and inequalities. I wanted to put a gender lens to it, so because this is important in decision making in public health ethics, because of the power dynamics and also the gender norms that are central in the debates around ethics. So we thought, okay, women, not only as professionals, but also as a woman, how do they feel? And within that, when we were kind of trying to analyze their interviews, we understood that there are 2 elements to it. One is about distributional justice, and another one is about procedural justice. Distribution is like, how do you resource allocation? Where do the funds go? How do women are the facilities available, and what sort of things are available for quality of care is available, where the public funds, who allocates the funds where they should go. So those are very distributional justice questions. However, one of the things from a gender lens perspective that we wanted to identify is that the power dynamics that happens during the decision-making process. Where do ASHAs stand? Because they are at a very low level. Although they're frontline workers, they're facing the pregnant women, they're facilitating the services. They have to go and encourage women in the villages to have institutional deliveries. Where do they stand? To have how do they exercise their autonomy and capacity to convince women to have a safe birth? So we wanted to explore both elements, because distributional justice in terms of numbers and figures very easy to portray in data, but non-material resources of which are more subjective in nature can be harder to interpret and analyze. And that's where we thought that we will be focusing our research into this element as well. And the second, one of the thing was about procedural justice, is like when there are negotiations happening in terms of whether women want to go to hospital for safe birth delivery or not, or how and also things like, do ASHA workers themselves have the capacity within the system to have that autonomy to exercise their knowledge, their skills, and their practices to convince women, or do they just follow the government protocol, basically. That's what it is. So do they have access to specific, in terms of their own future, do they get trained to improve? Do they get trained to do better? Do they have a career progression? And especially because they're working in a very resource poor settings. So how does that training affects their own procedures of and subjective relationship between distributional justice and also procedural justice? So these are kind of things we wanted to explore in the interviews, and some very interesting comments that came about, and how do ASHA women, ASHA workers actually negotiate their boundaries? How do they actually navigate the complex relationship between the public health goals and their own and the individual needs of the participants or the pregnant women and their own? And so their positionality within which they work is quite influenced by their social identity, because they belong to the village as well. They belong to particular age group. They belong to particular caste, and how the social positionality play a dynamic in the power relationship. So, for example, one of the quotes that one ASHA worker said, means the villagers think that we are very young, we don't know anything about this. Elder people think that they know everything because they have got more experience, and we are just trying to be a madam because we have done a course. So, this is something that they are within the professional settings, that's what they're expected to do, but the society does not allow them to sometimes give them that freedom to actually exercise their role. So from their primary positionality as a daughter-in-law or a mother or wife undermines the authority for health promotion, because elder people think they know better. So there are and secondly, because the society is very hierarchical, very patriarchal in India, even today in rural areas particularly, there are barriers to communication and from those who are above and below the caste as well. The caste system, I think it's very well documented in India. And so one of the women said the women from Muslim community, Badai and Chamar, who are the lowest of castes, are very difficult to work with because they are not able to take care of themselves or their children. That may be a perception of the woman who, because ASHA worker, is because she herself came from a higher caste, and she was kind of blaming the caste as an issue for women to be not cooperating for institutional delivery. So this social positionality does affect their boundary of work in their profession, and that is one element of social positionality. And the other one is is about professional positionality, where ASHA's own role is defined, and the boundaries get defined by the professional context within which they operate and they communicate, and how that limits their freedom to express and also to support the system. For example, they are the lowest in the healthcare hierarchy in the eyes of community and also the health system, because they are not educated till, say, even high school level sometimes. They may be very experienced, but they are not educated. They are not equal to other community health workers such as AWWs, which are Anganwadi workers who need to be graduated till high school level, or ANMs, auxiliary nurse midwives, who need to be graduated having a school or a diploma level, or MPWs, multipurpose health workers, who need to hold a diploma. They all do very, very similar work, because ASHA workers are in the very complex web of professional position. They get limited by those boundaries where they fail to, or not they fail, they become hesitant or restricted to exercise their knowledge and skills. So that they have both social positionalities and also professional positionalities, and within those positionalities their role is like a pendulum between the two. And of course, gender norms are there because multi-purpose health workers who are largely male, because they hold a diploma, they also do things like malaria awareness program. They have to go out and do wash programs, and the villagers think they are equal to doctors, but because they ashas cannot do treatment and they cannot do injections, they are not considered as equivalent to other health workers, whereas ANMs and male multi-purpose health workers are allowed to be a little bit more invasive, and that is something they said that it's very challenging. For example, they said when we have a problem, a woman has to be given injection, we have to contact ANM, which is auxiliary nurse midwife, and pregnant women will listen to them more seriously than us, although we are saying the same thing. Because medicine and injection can be only given by ANM. So they think ANMs and other healthcare workers are equivalent to doctors, but because even if we say the same thing. So this is something they said is challenging for a lot of women. So between those two positionalities, they try to balance both of their roles, which is in the sociocultural settings within which they operate. So they have a very indispensable roles. They fight taboos, as you have seen, in the quote that woman says that she was thinking of ghosts and other blind ways when we talked about taking immunization for her. And they also act as a very cultural interpreter. So their power is very subjective. They are daughters, they are mothers, and they belong to the village. So they have those access to their interpersonal relationship with pregnant women, and also know their personal vulnerabilities of individual women who are pregnant. They know their rituals, they know their interpersonal rituals as well. Having equipped with all that powerful knowledge, they still cannot operate, but with freedom within the position, occupational context, but within, and also in the villages. So, but they have to facilitate as a socio-cultural bridge bit in the health promotion activities. They have to keep focusing on going remove the myths and the biases that women have against all sorts of the programs that that government is running. So this is one of the pictures during the project that we took in a hospital, which is a district level hospital. The second challenge is about what I would call as logistical and systemic problem about spatial and institutional bridging. So now the villages, as you can see in the map that I have added, is one of the district areas, district headquarters, where you have institutional delivery happens. So this is place where you will have institutional deliveries, and then you have the yellow ones are about non-institutional deliveries. Places. So women have to travel all the way from those villages to this place, and this facilitation is very challenging because women don't drive. They have to call the ambulance, and if the ambulance doesn't come on time, then the women get blamed. That is one, like a spatial and temporal issues that a lot of women face, because the patient experiences are very poor sometimes, but because they're frontline workers, they would have to take the bait for that. And that they have sometimes said that this is something that they find it quite challenging, because everything boils down to them when they are trying to deliver the health promotion activities in the villages. Second one is a more of an institutional problem, where you have issues related to, for example, you have rent-seeking behaviors of the staff, where the higher level officials might take a bribe to even inject a woman with some sort of vitamin D, for example, or give them free iron tablets. They would ask money, and whereas ASHA worker in their household activities will say, it's free tablets, you have to just come to the hospital with me, I'll take you there, and you would have to, we'll give you the medicine, or the doctor or the ANM will see you. But actually, they just go, but they don't get treated with respect. The patients don't get treated with respect, and the staff asks for money. And that is something they say it's a constant problem for them, that institutional bribery can be challenging. It is very sensitive, it's very complex, but they have to bridge that gap between the rent-seeking behavior of the healthcare system or healthcare workers who are based at higher level in the hospital, and also with the participants or the pregnant women. And so that they struggle with both spatial and institutional bridging of their issues in terms of facilitating access to services for these women. So how do they meet those challenges? Of course, within their training programs, I think it is now 1 month, and they have got all sorts of like 8 modules that they have to cover to train ASHA workers. So one of the skills that they are trained is communications. So they have to, that despite resistance from the villagers, they have to continuously go and be persistent and patient, and say that you knock the door every time and tell women to come and eat their medicine or on time, adhere to their medicine, or go for antenatal checkups, or keep sanitation and hygiene, or eat healthy food, or whatever that they are getting trained for. And you need to keep your patients. You have to treat them with respect and friendly behavior. And that is something, that is one thing they are trained for. And some of the things is that okay, sometimes they give up. So they said what they do is they try to mobilize the support from higher level in the family and community. For example, if a pregnant woman lives with her in-law, so she will not go to the pregnant woman herself directly. She will try to persuade and convince the father-in-law, the mother-in-law, or her husband to send the women to the hospital. And this is sort of a patriarchal society within which there is, if you put authoritative pressure on women, that works. For example, one of the quotes says, if there is a mother-in-law in the family, we should first counsel her. If mother-in-law asks daughter-in-law to go for checkup and institutional delivery, then only the beneficiary would agree. So the permission needs to be taken from the entire family sometimes, rather than directly to the beneficiary, who is a pregnant woman. So another one says, even if after counseling, if they don't agree, then we will take the help of the village sarpanch, who is the head of the village, or a higher up official like an Anganwadi worker or an A&M or a clinician, and they will call them, and they said they will go to their house of women, and then they will try to convince the beneficiary for institutional delivery. So they try to use all the tricks what they can find within their communities, in communities of practice, as I would call them, to make women go for institutional delivery. Last but not the least, one of the biggest challenges that if nothing works, they will just force them. I think that's quite unethical, but actually one of them did say that they have to use coercion tactics sometimes for women to actually make sure that they have a safe delivery. So one said we literally gave immunization forcefully on the road, not while she was resisting. So, you know, they operate in a very complex environment. But slowly but steadily in their course, they said building trust is probably one of the key elements of their role, because they belong to the village. They know the women themselves. Their families know the families of women and other villagers. So I think they try to rely more on personal relationships to in the professional context within which they operate. This is not only during when they are in their role as a ASHA worker, but also outside in a social context. They utilize their social positionality in other issues to stand up for community members. So, for example, one of the quotes says that, you know, when they reach to the delivery room, the sister talks to them as if they were a garbage and tells them to stand far away. But if there is an ASHA with the beneficiary, nobody treats them like a garbage. So she exercises that side of, you know, her role with the community members, that if you come with me, people will treat you better. Yeah. if pregnant women go on their own, they won't get treated nicely at primary healthcare centers. So this is something they adopt as strategies to convince women for coming for institutional deliveries. So just to sum up, there's a lot of data more, but I think for this talk, I thought I'll just keep it short and brief. So just a summary of my talk, I would like to wrap up by saying that ASHA workers work within a very authoritative model of health promotion, and they are constantly challenged for meeting targets, which could be through bribery. Sometimes they are asked to falsify records to meet the performance targets and monitor. And also they have also inherent motive, because the more targets they meet, the better incentives they will get. So there is, they try to negotiate their boundaries within that very hierarchical and paternalistic health system, in which they are both enabled through their social relationships and social positionality, and also constrained because they know women too well. Yeah, so many of their strategies involve mobilizing authority and using the patriarchal system itself in the professional settings to be able to facilitate their own to facilitate their work. So, but overall, they contribute towards social and health systems change. And their own role probably may change if the health systems change. So, my reflections would be, in terms of ethics, there are both positive and negative implications for procedural justice, so that ASHA workers are not treated as at the lowest of in the hierarchy of healthcare system, by developing their own capacities through further training and autonomy of ASHA workers, and they should be treated with respect. And there is a very intersectional perspective on relationship between close to community workers, who are ASHAs, and other providers who are. So there has to be a balance between how the processes and the products of those health systems, which is the hierarchy in the health service delivery with regard to procedures, justice, and the nuances around theory of justice work. So it creates some space for articulation for both client and provider voices and narrative. And I'm still working on this. It's not finished. I don't have an answer for all from terms of philosophical underpinnings, but from a project perspective, I think this is something we are trying to deliberate. And I'm leaving, thank you very much. I'm leaving this screenshot of 13th of March, literally last week's BBC News, again mentioning about how India's frontline workers fight for better pay and recognition. So I think this is something that is ongoing, and hopefully they will get a better treatment and capacity in the healthcare system. So thank you very much indeed for your listening. Thank you. I'm done.
Thank you, Mina. No, good job. You said you were going to show us a screenshot. Oh, yeah, there it is. I see the frontline workers, right? Yep. Yep. And do you think the situation compared to some of the other countries you've been in is better or worse in India in terms of the discrimination of lower social economic castes or classes?
I think I'll leave the economics out of it. I think economics it's a different factor. I think if even if you're a lower caste person, but if you're economically rich, I think the way you will get treated is very different from if you're a lower caste and economically also poor. So I think I will leave when I'm talking about cost, I think economics, there is an economic element to it, which is very powerful in the dynamics of how people behave with them. But in terms of how society functions, even today, I think I won't say not in the super rich category of India, but a middle class, lower middle class socioeconomic groups, I think caste is still quite dominant. It is still quite dominant in terms of day-to-day activities. day-to-day activities. It is unfortunately, that is a truth. It is changing, but this change is not rapid. It is a very slow progress, but there is a progress. There is a hope.
And if you think of a suitable name for the, I'm trying to think what you'd call, whether it's like a chaperone or the protector who goes there, because if they have this, as you said, the person there, they're going to be treated with dignity rather than just, or more dignity.
But her acronym is very appropriate. Asha means hope. So I think her acronym is very appropriate for the role she has, but her position does not provide much space to exercise that hope. I think that is what challenging is. I think having spoken to a lot of ASHA workers and seen them, their own social positionality dominates their work. If the ASHA, because she's a woman that comes from the same village, if she's a daughter-in-law of a village head, people will listen to her more. But if she was an ASHA worker of a average person in the village, people will not listen to her more. So I think the power dynamics is not only because she is an ASHA worker, but also her social position within the community. I'm daughter-in-law of this and that. If she belongs to higher caste, people will listen more. If the ASHA worker is from a lower caste, people will ignore her. Although both of them probably would be doing exactly the same job. And that is something, it is very bewildering sometimes to see. Having been in the field myself for a few years, and it's just, I can't give answers, but I think it is changing. I think ASHAs are speaking up, as you saw in the screenshot, there are a lot of strikes happening, and their honorarium is around 7,000 rupees. It's increased now, but because they are not as a government employee, they have a very different status, whereas the next level is A&M or AWW. They all get paid from the state government budget, so they're government employees. They're not volunteers. So I think that that's why the news always comes about asking them, oh, can we become government employees? Can we get pensions once we retire? Those sorts of things. So that's why all this kind of take up is there. So much focus on them is there. How to mobilize these women and to have capacity strengthening of these women.
Okay, yeah, thank you, Meena. I'd like to open for other colleagues, questions or comments.
It's quite late in the evening there. I think people are very tired.
Well, in fact, we're people, a few from Bangkok, but a few from the other parts of the world as well. Yeah,
I think it's very late. I see it's 2 o'clock here, so it's quite late there.
And just on before 9 p.m.
Yeah. I think I don't think so people have any questions, but you can read about them. It's fine.
Okay, does somebody else have some questions? Suma, have you had any experience in your visits to India recently? And Dosama, you did field work in different parts of Asia Pacific for ESCAP.
Right. No, that's okay. I think that's fine. Thank you. Is there any next speaker here?
No, anybody like to ask any comments or questions? Yeah, our Manyao is missing in action. Dr. Sheriff is missing in action. I think people are not used to the Skype anymore. Anyway, I open.
Okay, I'll stop sharing my screen at least. I think that should help.
You can stop sharing the screen. Yep. Okay.
Yeah, I think it's confirm stop sharing. Okay, right. But thank you for the opportunity. I think there was some audience, which is not bad.
Yeah, Nader said it's very good talk. Nader's in Japan. Japan is 11 p.m. So you're doing a good job, Nader.
Oh yeah. It was very good. Yeah, but yeah, India is such a complex society. You know, it's for us who haven't lived there. It's really hard to understand. My aunt, you know, my aunt married an Indian, and she has many children. Some of them are now in the UK. One is in the US. And one of the things that surprised us very much, and we still don't understand it, like they were very happy, and her husband once went back home to visit his family, and he never came back. And what she was told was that he died. But what she also heard was that you know, his own family, like there were people who were, you know, unhappy with him, and they kind of killed him, you know. And you know, we were so much puzzled, like how something like that can happen. And she was told that, you know, it would never work if she even tried to, you know, find what happened or who did that or what. So basically the family, like, you know, life ended like that. And she you know, it's for us really, things that happen there, some of them are really not easy to understand. So, you know, I listened to your presentation and it's so interesting, but we have nothing to compare with that. I mean, it's a very, very unique society.
And no, but the role of community health workers is quite common if you go to parts of Africa, and even if you go to Myanmar or Thailand.
Oh,
They're comparable to any other community health workers. I understand people don't have field work based, you know, thing much. But as a public health person, field work is something that we regularly do. I think if you go to Nepal or if you go to Bangladesh,
do they
India,
have a
Pakistan,
similar caste system, or like in India, or?
Nepal probably has, because it's a Hindu society. Uh, Thailand doesn't have a caste system, but they have a class system. I don't think they have a caste system.
Uh-uh.
But wherever the Hindu societies are there, I think there will be a caste, some sort of caste system. Um, so I think this is, but what I'm talking about is more about community health workers and their roles. I think community health workers is very comparable to any country you go.
Oh, I see. Yes.
Yeah, I think they are everywhere, whether it's in Iran or whether it's here. It's same. I think the societal structure, I understand it's very different, but professional roles within public health system is quite common. The role of community health workers or skilled birth attendants are very, very common. I mean, Africa is full of similar sorts of community health workers roles.
Like the example I can give you, like in Afghanistan, if you are a health worker, when you are providing your services, you have to be very mindful of the tribal system. Like,
Oh yeah.
for example, is it a Pashtun or is it Tajik, or, you know, so you shouldn't mix it.
Same
So
in India as well. In India as well. That's why in Afghanistan, if it is tribal system, in India it's caste system.
yeah. So yeah, there
Terrible.
are some
So it's the same thing. Like if an Asha from one particular state, first of all, if you don't have a domicile in a particular state, you cannot function. You have to
mm,
belong to the community where you are living. You can become, oh, you can only serve them. You can't say, oh, I want to be an Asha, but because there are 5 Ashas in my own village, I'll go to the next village and become Asha. No, it doesn't work like that. You have to belong to the same community where you serve.
Yes.
That is the condition. Whereas if you are because she's at the lowest level of the system, healthcare, as a healthcare worker, if you have like nurses, or if you have got other ANMs or nurses or doctors, they can get, transferred to one village to the other for job opportunities because they are salaried people. They can be posted, but Ashas can't. So I think that is something that is very interesting to look at. So yeah, but this is just one element of the project. It was a massive project that we are still trying to reel with the data, lots of quantitative data as well, and how the systems work. So, but I thought I'll just, because it's ethics, so I thought I'll just focus on the ethical elements of that.
Thank you very much. Thank you.
Yeah. Thank you, Nader, for your comments.
Thank you for your presentation. Yeah, I hope you you complete this project. Yeah, it seems to be a very big one.
It is a big one. Yeah.
Good luck.
Thank you. Right. Thank you, Daryl, for the opportunity.
Well, thank you. Anybody else would like to share any comments? Questions? Okay, so, well, thank you, Meena. Thank you, Nader, for presenting. And I've made a video recording, and we missed 2 of our scheduled talks. We missed 2 of the people who said, oh, I want to join since I couldn't come. But I think some technical issues in terms of how they join Skype or time confusion. So thank you very much, both of you, for joining.
Thank you very much for the opportunity, and lovely to see all of you. And hope to see you in person at some point of time when I get a chance to be part of the conference again in person. Yeah. Thank you very much indeed. Yeah. Take care, everyone. Take care. Bye-bye.
Bye.
Bye. Bye-bye. Good night. Thank you, everybody.
Good night. Bye. Sleep well, everyone. Bye. You have a long day. Bye.
Bye-bye.